Hi everyone, I'm David Lee, an electrophysiologist from Halifax. Martin and I are going to chair this next session, which is going to take us from the kind of cutting edge of inherited heart disease back to something that's a little more home turf for most of us clinicians. So we're going to talk about risk stratification in inherited arrhythmia conditions, and our first speaker is going to be Dr. Julia Cadrin-Tourigny. Dr. Tourigny is a cardiologist and electrophysiologist with a specialist in cardiogenetics at the Montreal Heart Institute. She completed her training with a postdoctoral fellowship at Johns Hopkins, where she focused on ARVC, arrhythmic risk predictors in genetic conditions, has been her main research focus since. And she's going to talk to us about her approach to risk stratification in ARVC.
Thank you for the introduction and the very well pronunciation of my name, which I know is a challenge. Okay, so thank you very much for the invitation. It's a pleasure to talk about risk stratification in ARVC, a topic that I really like. So why do we care about risk stratification in ARVC? Well, we know ARVC is a significant cause of sudden cardiac death, so it's scary. And it affects particularly young and athletic patients. So we really don't want these patients to die. They're young, they don't have competing risk, but at the same time, we want to avoid the disease of having a defibrillator, which, of course, you know, has short and long-term complications. So ideally, we want to be able to predict exactly which patients are going to have a sudden cardiac arrest or ventricular arrhythmia, and exactly which one need a defibrillator. The problem is that it is hard to make predictions, especially about the future. And there's so much truth in that truism that has been said by many important male before me, but I say it today too. So before we delve into risk prediction in ARVC, and I don't want to spend much time here, but it's important to make sure that's another truism. Before you make risk prediction in ARVC, you have to make sure that what you have in front of you is ARVC, and that sometimes may be difficult. I think the most common reason why people are labeled as ARVC and they don't have it is for isolated, non-specific finding on the MRI, which are not supported by electrical disease, and ARVC is usually primary and electrical disease. So not too much time here. There has been a lot of work done in the past 20 years, I would say, to try to find the risk prediction, risk predictors of ventricular arrhythmia and ARVC. We have to recognize that the research in ARVC has been based on retrospective study, so we don't have nice prospective randomized control trial of ICDs versus placebo in ARVC, showing that ICDs prevent sudden cardiac death. We know that in cohorts with ICDs, patients have a lot less sudden cardiac arrest events, but we don't have prospective data showing that. So with all this data, there has been an organization into consensus and more recently in guidelines using all these predictors. So it is usually recognized that you need an ICD in secondary prevention, and in primary prevention, depends on different predictors, and more recently, in the last cardiomyopathy guidelines from the ESC from 2023, which came back to the term ARVC, which I think was a good idea, the use of the ARVC risk calculator was recommended. So what's the idea of having a risk calculator? So a risk calculator pretty much helps you take all the literature and the clinical data that you have and organize it so that you can bring it to the clinic and make it useful easily. So it helps improving prediction by taking many predictors at the same time, even if they have different weights, interaction, additive values, even if they are continuous predictors. And this gives you an absolute risk that you can use to discuss with patients about a defibrillator or not. How do we make risk calculators? So first, we determine the population that we include. That's important because you can't use a risk calculator in a population that you did not study. You determine the candidate predictors from prior literature, the outcome. That's also important. We're going to come back to that. We assess the performance, and importantly, external validation has to be conducted. And for this, you need quite a big cohort because you need 100 patients with and 100 patients without an event. So the ARVC risk calculator was based on prior literature, taking the best candidate predictors that were there, started with 8 predictors, stayed with 7. So the only one that got kicked out was left ventricular ejection fraction that was not a predictor. So age male sex, syncope, number of PVCs on a 24-hour Holter, leads with T-wave inversion, non-sustained VT, RVEF, and the outcome that was predicted was any sustained ventricular arrhythmia. So ICD-treated events, sustained VT. The median speed for the VT in patients in whom we had this information was 224 beats per minute, so there was not a big burden of very slow ventricular arrhythmia, however. So the population, so only definite ARVC, so those patients who don't have definite ARVC were not studied there. Primary prevention, so we can't apply the risk calculator to secondary prevention patients. And I mean, common things are common in everything, but in genetics here, so the common patients are the plakophilin 2 patients, and these were very well represented, while very rare genotypes. And for example, TMEM43 that we heard about this morning was very poorly represented, and I would not use the risk calculator in these patients. External validation showed that the model works well, and that the C statistic is very acceptable, between 0.70 and 0.78. The HCM calculator has a C statistic of 0.74. So what does this number mean? Pretty much it tells you that between 70% and 78% of the time, the risk calculator will give a higher risk to a patient with an event versus a patient without an event. So the risk calculator is not right 100% of the time, so we have to stay humble when using these kind of measures. It works well in patients that are genotype positive, those who carry a gene causing ARVC, even better in PKP2 patient, doesn't work very well in desmoplakin patient, which seem to be a different beast, seem to work better than all the prediction based on a single risk factor, such as what we have in consensus and guidelines. And then different iterations were tried on the risk calculator. So exercise, even if it increases the risk, doesn't add up to the risk calculator. The risk that is associated with exercise is included in all the other predictors. Programmed ventricular stimulation can be used to refine the risk prediction if needed, so add it on to the risk calculator. Periodic update, so when we see the patient every year, we can update the risk with the new findings. Gene specific, so there's a specific calculator for PLN that should be used. Maybe there's going to be one someday for desmoplakin. And left ventricular fibrosis, so we have been working on that. LV fibrosis is a predictor, but in definite ARVC patient doesn't add on to the model. Another important part, so we have tried to, derived another model for rapid ventricular arrhythmia, which has not been validated, so I prefer using the model that has been validated. But what I remember from this is that certain risk predictors target rapid ventricular arrhythmia better. So younger age, male sex, number of leads with T-wave inversion, and especially PVC burden are important for that. So I keep them in mind when I see patients. So the question of the threshold, of course, everybody wants to know. So we have this absolute risk, we have a number. So what's the magical number where everybody should get an ICD? So there's no free lunch. The lower the threshold, the more people get ICDs, but you never miss events. And the higher the threshold, as you can see here, solid colors are patients with ICD. So you increase the threshold, less patients get ICD. Dashed colors are those without ICDs. So dashed red, red being events, are those patients who are not protected by an ICD. So the higher the threshold, less ICDs, but more missed events. So there's no perfect threshold, of course. So there are many different considerations that we can think about when thinking about a threshold. So what is exactly the balance between complication and missed sudden cardiac death? So what's exactly the number of complication that is equivalent to one sudden cardiac arrest that is missed? So there, we know the rate of complication, we know the rate of inappropriate shock, but nobody really have an answer to that specific question. The cost limitation, for sure, is not really a consideration in this very young population without any other comorbidities, usually. And how close is sustained ventricular arrhythmia to sudden cardiac death is important because I told you we predict sustained ventricular arrhythmia, but not directly sudden cardiac death in this population. There has been a suggestion from prior prospective studies in other types of patient, old studies, that maybe two sustained ventricular arrhythmia or ICD-treated events would equate to one sudden cardiac death, but it's not exactly the same population. And this is important when we want to Well, when we're tempted to use exactly the same threshold for ARVC as we use for HCM, so the HCM risk calculator, so the cohort that led to that, when you see the red represents sudden cardiac death and aborted sudden cardiac death, so the proportion of event being these types of event is much higher in HCM than in other types of arrhythmogenic cardiomyopathy, ARVC, but also lamin and PLN. So this needs to be kept in mind, even if we think that these other types of events are significant, and we should probably calibrate our threshold a little bit differently here, and of course a little bit higher. And then the next question is if this threshold should be the same for everyone and everywhere. So we know when we see patients that patients' assessment of risk can be different from one patient to another. So the burden they put on complication versus the fear of having a sudden cardiac arrest. And even more striking, and you saw this data this morning, this threshold is clearly not the same everywhere. And us North American, because our pattern of practice in Canada are more North American than European, even if some would think differently. So we tend to implant 3 times more ICDs than in Europe, but Europeans don't seem to kill patients more. So I don't think there's a true, or it doesn't tell you the specific threshold, but I think it makes us realize that it's hard to come up with a very specific threshold, and these differences will remain with time. So all of that being said, my humble approach to risk stratification in ARVC. So I think in secondary prevention, there's not much to say. ICDs are recommended. In primary prevention, I think the first thing is in definite ARVC patient, the risk of ventricular arrhythmia is relatively high, and I always keep that in mind when seeing patients. So if someone really, really wants a defibrillator, I don't think I would refuse. And then I use the risk calculator. The sweet spot where I really start thinking about an ICD, somewhere above 10 to 15%, and of course the higher the most convincing. I use PVS in selected cases when I don't necessarily agree with the patient or we need to kind of refine our prediction. I use with caution when seeing non-classical patient, and I see more and more mixed phenotypes. So big families, PKP2 families, like French-Canadian families with lots of uncles and aunts, and someone has coronary artery disease, had bypassed in the past, has fibrosis and an ischemic disposition, and has some features of ARVC. Well, I'm not sure how the risk calculator works in these mixed patients. I don't have the answer. And then I remember some of the features of these more rapid events that are scary. PVC burden, being young, being a male. I'm a little bit more scared of these patients. And if I don't implant an ICD, I follow up patient. I re-stratify them every year. So thank you very much.
So our next speaker will be Dr. Steinberg. Christian Steinberg is a cardiac electrophysiologist and an inherited arrhythmia specialist at the Quebec Heart and Lung Institute, Laval University. He's the director of the Inherited Arrhythmia Clinic there, and he's going to talk to us about who needs a primary prevention ICD in hypertrophic cardiomyopathy.
Thank you very much for the introduction, and good afternoon. These are my disclosures. And I don't know if this, okay, the animation doesn't work. As you all know, hypertrophic cardiomyopathy remains among the most common genetic cardiomyopathy and still is an important cause of apparently unexplained sudden cardiac death. And risk stratification for primary prevention ICD is a crucial part of our longitudinal follow-up in these patients. And unfortunately, the animation doesn't work. This teaser slide is the cine of a cardiac MRI of one of our patients, and just a nice example to show how stressful shared decision-making can be sometimes for the doctor. This is a young patient in his 30s with massive HCM, 42 millimeter septum, no indication for reduction therapy. And he refused an ICD for over 3 years, actually even quit follow-up, so gave me a lot of sleepless nights, eventually came back and said, I'm ready for an ICD, and said, oh, cool, you're still alive, that's great. And And we put it in, and then he's still doing well. But just to tell you, it's sometimes more stressful for the doctor than for the patient. And it is undisputed that primary prevention ICDs have dramatically improved the overall outcome of our HCM patients, and the contemporary disease-related mortality has dropped to 0.5% a year compared to historical values from the 90s of up to 6% per year. This is all-cause mortality. And if you compare contemporary cohorts, you see that the life expectancy of HCM patients is comparable to the general unaffected population. And more specifically, the risk of sudden cardiac death has lowered to an all-time low at 0.23% per year. So these are great news. And with these data, we could say, so why don't we put an ICD in every HCM patient? Well, the problem is this comes at a cost, and the costs are the device-related complication and the long term. And we have seen data from this important study before today. And in particular, in younger patients, the long-term risk is significant, in particular inappropriate shocks or lead problems, which can have annual rates of up to 6%. So it still remains a challenge to identify the right patient for the primary prevention ICD. What kind of tools do we have? What do the guidelines say? So over the last 10, 15 years, two different concepts evolved in Europe and North America / the US respectively. Some authors see this as some kind of clash of cultures. To be honest, we should not forget that there's still substantial overlap between both strategies, and I think it's rather time to reconcile these different approaches than to deal in absolutes. So the US approach can be described as a major risk marker strategy. It's based on the presence of individual structural or clinical risk factors / risk modifiers that you're all aware of, and the US guidelines have integrated them since 2003. In the presence of at least one of these risk factors, you have a class 2 indication, 2A indication to insert a primary prevention ICD. This concept has been extensively validated in a lot of international external cohorts. However, these are all retrospective data. Shortcomings of this approach is the individual risk factors are unweighted, and for some of them, there's just a binary classification, for example, the presence of maximal wall thickness, which does not really reflect the dynamic spectrum of the underlying pathophysiology, and the Americans always excluded age. When you compare this model to the European model, you will see that it's characterized by very high sensitivity, 87 up to 92%, but a very modest specificity. This model evolved over years, integrating a few more recent structural risk modifiers. They're all CMR-based, such as the amount of LV fibrosis, which has been shown to increase the risk of sudden cardiac death with a cutoff threshold of at least 15%. Not only the amount of LV fibrosis is important, but also the way how this evolves. More recent data showed if you have a rapid progression defined as an increase of scar mass by at least 1.5 gram per year, this is an independent predictor of adverse cardiac outcomes. Left ventricular apical aneurysm has also been shown to be an independent risk factor of ventricular arrhythmia. You can find this depending on the imaging modality you use in up to 10% of your HCM cohorts. Non-sustained VT has been a risk modifier since the very beginning, but has been downgraded over time correctly because more recent data show that only non-sustained VT with so-called high-risk features like an increased number of consecutive beats at a very high rate, over 200, is an independent risk factor of sudden cardiac death. Because as you all know, non-sustained VT is very common in this population. On random ambulatory rhythm monitoring, you can find it in up to 54%, in particular if you use a standard definition of at least 3 consecutive beats of 120 or faster. And most of these patients are asymptomatics. The Europeans, on the other hand, they developed a multivariable risk score-based approach, which is now referred to as the ESC score of 2014, which is actually based on the initial work of Konstantinos O'Mahony's group and co-workers, which was a multi-center study where they developed this score, and it estimates your risk of sudden cardiac death, the cumulative risk at 5 years, and classifies patients into 3 different strata: a low-risk group, less than 4%, and a high-risk group of 6% and more. It comes along with a nice app that you can download and use. Compared to the US model, it's characterized by very high specificity, 92%, but a very, very modest sensitivity, 33–40%, and the positive predictive value remains quite poor. Shortcomings of this model is, on the one hand, a very problematic selection of several parameters, like the LA diameters measured in 2D, which is obsolete since over 20 years. They use NSVT as a binary parameter, and the LVOT gradient, which you can modify. And they omitted other well-established risk factors like MRI-based quantification of fibrosis or left ventricular aneurysm. Other shortcomings are they excluded quite a bunch of particular HCM subgroups, pediatric patients, of course, athletes with HCM. The model is basically only validated in septal HCM. There was almost no apical HCM. Patients after reduction therapy were excluded. The overall event rate was quite low, and the model has a very moderate discriminability between the highest and lowest risk groups. The difference of annual event rates was only 0.4%. That raises a lot of questions. A few general remarks: we see both models have limitations. So I think the risk of sudden cardiac death in this population, like in almost every other hereditary cardiomyopathy, is dynamic over a lifetime. It's not static. We have to integrate progression of structural and clinical findings as well as age, and none of these models has actually been prospectively validated. The positive predictive value of both approaches is modest at best. They have good negative predictive value, but not positive. Why is age important? Because data have shown that your disease-related risk of sudden cardiac death lowers significantly over time, in particular once you hit the level of 60 or more. So with these limitations, what would be a reasonable approach in clinical practice? So I think a good approach at this point would be to use the best of both worlds and use the models in parallel to combine the high sensitivity of the US-based model with the high specificity of the European model. We should not forget, in the end, it is a shared decision-making process, and we have to integrate and respect the patient's preferences and the patient's perception of risk and their goals and values. And a first step to reconcile actually these two worlds has just been recently made by the brand newly published updated US guidelines from May this year. I like this figure so much, in particular in these times. So where the US guidelines just integrated into their algorithm the European 5-year risk estimation. My take-home message is actually, I think we have to go a step beyond that. I think it's time for really novel, better risk models, like dynamic algorithms, and I hope, or I wish myself, that this next model comes from Canada, maybe from HiRO. So I'm thinking or dreaming of a model where we combine well-established traditional risk factors with way more and a more specified approach, integration of risk modifiers to distinguish between different HCM phenotype subgroups like apical versus septal, integrating genetic high-risk features. Data remain conflicting, but I think it's fair to say there is now a reasonable amount that say there is some maybe polygenic substrate that might guide us. Age has to be integrated and other yet to be identified biomarkers. Thank you for your attention. I think I should be in time.
Thank you. And I think we'll do questions at the end, if that's okay. Next, I'll introduce my friend and colleague, Dr. Ciorsti MacIntyre, who's an associate professor and director of our Inherited Heart Disease Clinic at the QE2 Health Sciences Centre in Halifax. And she's going to talk to us about when to implant a ICD in long QT syndrome in 2024.
Thank you, David, and thank you for saying my name so correctly. I really appreciate it. It's been the plague of my life. I'd like to thank my parents for that. So my disclosures are not relevant to this talk, but I did create the talk on a Mac, which has created some interesting formatting issues. So hopefully we'll get through it. So my goal is to challenge some longstanding paradigms in long QT syndrome management and to discuss when an ICD should, and probably more importantly, should not be considered. And kind of carrying on with the theme from the last two talks, I think we still live in a gray zone when it comes to risk stratification in these patient populations. So I think this is what we fear. When we first heard about long QT syndrome, it seemed like a very malignant condition which killed lots of young people. And I think we still live with some of that legacy now. But through the years, what we've discovered is that the rates of breakthrough events, the rates of mortality have actually been decreasing in the published data, and overall the mortality rate for long QT syndrome is actually exceptionally low, particularly when patients are appropriately risk stratified and treated. So why has the event rate changed? Has long QT syndrome changed? Well, I think we have a growing recognition of a large concealed asymptomatic patient population, so it's swung the pendulum. We've also had some evolution in treatment strategies for how we manage our patients with long QT syndrome. We love beta blockers. Hopefully, we'll have better therapies moving forward, but for a long time, beta blockers have really been the cornerstone of our management of long QT syndrome, and they work. And a lot of the failures of beta blockers that we've dealt with have related to non-compliance or perhaps the use of a QT prolonging agent in our patients, which have led to those breakthrough events. So for a long time, the mainstays of treatment have really been these two, nadolol and the defibrillator. And based on the effectiveness of beta blockers, they're really the cornerstone with guideline recommendations suggesting universal use of beta blocker therapy. I love pointers. But since the evolution of treatment has really evolved, so left cardiac sympathetic denervation is now an important tool that's available to our patients. And we also have gene-specific therapy. So the use of mexiletine was shown to really improve QTc values and event rates in patients with type 3 long QT syndrome. And there's also a role for mexiletine in some patients with type 2 long QT syndrome, as we heard earlier today. There's also a role for atrial pacing, particularly in patients with type 2 long QT syndrome, where we see an impressive shortening of the QT interval. So instead of just universal beta blockade and perhaps a defibrillator for our patients, I think the time of one-size-fits-all therapy has really changed, and we have to try to use a more patient-tailored approach when treating our patients. And as much as that pendulum used to be towards the end of worrying about everybody with long QT syndrome, and then it's kind of swung in the other direction as we discovered this lower risk patient population, there's no question that there is a group of patients that we do need to worry about. So there's different gender, QTc, genotype, symptom, and age-related factors that we have to think about when meeting these patients in the clinic. So who do we worry more about? So symptoms matter. So in a patient with a previous long QT attributable symptom, so malignant sounding syncope or cardiac arrest, for example, those patients have a higher rate of a recurrent event. And we also know that genotype matters. So patients with multiple long QT causative variants, long QT3 and long QT2, certainly have higher event rates than our patients with type 1 long QT syndrome. We know that the QTc value matters as well. So the longer the QTc on average, the higher the event rate for those patients. And certainly cardiac arrest matters, particularly in our non-type 1 patients. So about 14% of patients who've had a survived cardiac arrest prior to initiation of beta blocker therapy may have a recurrent cardiac arrest or death within 5 years, even on beta blocker therapy. So it's really important that we identify these patients and find out how to treat them most optimally. So I think if we look at the guideline statement, there's really clear documentation in these guidelines that in our patients who've had a cardiac arrest that we should implant a defibrillator. Certainly 2 years ago, we talked about the fact that maybe in some of our type 1 patients who are not on therapy, not diagnosed, who have a cardiac arrest as their sentinel event, that there may be a role for medical therapy in them. But for most patients who have cardiac arrest, particularly with non-type 1 long QT syndrome, I think most of us would agree that a defibrillator would be in order. We've seen data from large registries that show that defibrillators can reduce mortality in patients with long QT syndrome, but we know that Defibrillators aren't benign. So if we look at long QT syndrome patients in particular, about 31% will have some type of defibrillator issue, whether it's infection, lead dislodgement, lead fracture, tricuspid valve insufficiency. We know that defibrillators aren't benign, particularly in this younger patient population who we hope to survive for a long time, who may see many leads and many devices in their lifetime. So let's think about some cases. Just to spice it up, it's late in the day, you've had good focus all day, so let's think about a 45-year-old woman with type 1 long QT syndrome and depression who comes to the office with syncope. Her medications include atenolol and escitalopram, and her QTC on average is around 520 milliseconds. Who's going to recommend a defibrillator for this patient? We'll go old school show of hands. 1. Okay, so either everybody's tired or everybody's against an ICD. Well, turns out we have to think broadly about these patients. So we know that the beta blocker selected matters. We've heard this earlier today. We know that beta blockers like metoprolol and atenolol have a higher rate of breakthrough events compared to propranolol and nadolol, which work best for long QT syndrome. And that's why they really are the beta blockers of choice, and we have good data to support their use in the long QT syndrome patient population. And when we look at the guidelines, they say that we can implant a defibrillator if a patient has syncope on beta blocker therapy, but does atenolol really count as adequate beta blocker therapy in long QT syndrome? And I would argue that it doesn't. I would argue that we should have our patients on the best beta blocker for treatment. What else can we modify? Well, I will never suggest that we don't treat depression in patients with long QT syndrome. I think we'd be doing people a disservice with that, but I do think we have to be thoughtful in terms of the types of medication that we use. This is my favorite table from our update on management of the prolonged QT interval from the CJC earlier this year. And there are antidepressants that are at lower risk compared to medications like escitalopram. So perhaps choosing a more QT beneficial SSRI would be another helpful intervention for this patient.
I really like that table.
It's my favorite table. I have it in my office. I use it all the time. Now let's make, yeah. So let's go to case 1B. Same patient, but now she has syncope on nadolol. Who wants to put in a defibrillator now? Couple fingers, not a lot of hands. Okay. Now she has syncope again on compliant nadolol therapy. It's worrisome. This is not vasovagal syncope, and that's a great question.
Still on escitalopram?
So many good questions, Jason.
Is the QTC still 520?
Exactly the same.
Oh, great.
Now, I know, I'm trying to be tricky at the end of the day. So, you know, previously, beta blocker non-adherence, syncope on a beta blocker, or beta blocker intolerance equaled a defibrillator in patients with long QT syndrome. And we know from last year that there are certain people in whom intentional non-therapy can be an option. That would not be great in somebody with malignant syncope with type 1 long QT syndrome. But we do know that left cardiac sympathetic denervation plays a role, particularly in type 1 long QT syndrome. And some patients will even have a shortening of their QTC post-denervation. So it can shorten by a mean of 60 milliseconds when done correctly. And there's many favorable effects for long QT syndrome with LCSD. And if you can shorten your QTC value below 500 milliseconds, the curves actually look quite promising compared to those patients in whom their QTC remains above 500 milliseconds after denervation surgery. So in this patient, you know, did she have syncope while compliant on nadolol? Yes, but you could make an argument that treatment intensification doesn't necessarily have to include a defibrillator, and you could use shared decision-making to consider whether addition of left cardiac sympathetic denervation may be an alternative to installing a defibrillator in this case. Food for thought. Let's go to one of my hardest scenarios that I deal with in the clinic. So a 25-year-old with type 2 long QT syndrome comes to clinic as part of Cascade family screening, and her QTC sits around 500 milliseconds, just above. She's on nadolol 60 milligrams at night, and her compliance is excellent, and she's never had syncope. Who's going to recommend an ICD in this type 2 long QT woman on nadolol who's asymptomatic but with persistent QT prolongation above 500 milliseconds?
What kind of mutation does she have?
That's an excellent question that I'm not going to answer. Because you're stealing my thunder for the next slides. Okay. In the interest of time, if we look at the European guidelines, there's a 2B recommendation that in patients with a pathogenic mutation in KCNH2 with persistent QTc prolongation above 500 milliseconds, it's reasonable to consider a primary prevention ICD. And just to Christian's point, I think when we're looking at these patients with long QT syndrome, we have to consider whether there may be other high-risk features that would push us towards an ICD. And those high-risk features can include QTc values above 500 milliseconds, type 2 and 3 long QT syndrome, being a type 2 long QT female, particularly if you're under the age of 40, if you had early onset of symptoms, so under the age of 10, if there's recurrent syncope, and also variant-specific features like Christian mentioned. So poor variants in type 2 long QT syndrome are more concerning, for example. For this patient, thank you, Mac, she is asymptomatic, so that's favorable, but she does carry a KCNH2 variant as a postpubertal woman under the age of 40 with a QTc above 500 milliseconds, which should give us pause. Now, it's interesting, in the last number of years, there is this new risk stratification score that can be considered the 1, 2, 3 long QT score, and millisecond for millisecond, patients with type 2 long QT syndrome and type 3 long QT syndrome do carry an increased risk, but really above 520 milliseconds, I don't think any of us would really debate the potential merits of considering an ICD, but at this level, you know, shared decision-making really is a significant part of what we do in the clinic. So I'm not going to answer the question about what we could do because I think it's tough and it sits in a gray zone and would be good food for thought and discussion. I think whenever we're considering not moving forward with an ICD, it's really important to remember that our patients do have to be optimally managed, or as one of my colleagues says, not optically managed. So we want to make sure that we do have them on the best disease-specific treatment. And I think that can also be flipped around. In our patients with ICDs, we don't want them receiving shock. So a defibrillator should not be seen as an alternative to medical therapy for our patients with long QT syndrome or really any form of genetic heart disease. So to conclude, I think it's important that we continue to challenge old paradigms in long QT syndrome management, and sorting out what to do with this intermediate and high-risk cohort will continue to be an important part of what we do. We have to remember that there are genotype-specific therapies that we should consider when seeing these patients. We've moved beyond just the beta blocker and ICD as part of our treatment program, and I really hope we continue as a country to find ways to get left cardiac sympathetic denervation access for our patients, which remains a huge challenge and can be a very important adjunctive measure for management of these patients. So thank you very much.
Thank you. Okay. We'll start off with questions from the audience. Andrew, your hands up was up first.
There we go. Okay. So this is just a reminder about Kirsty's last comment, an excellent presentation. So you remember Joe Attella from Edmonton led a conversation about who across the country was doing LCSD and where and how often and whether they had a target program and so on. We landed on 2 target programs, one in Edmonton and one in Quebec City. Jeff Healy tells me last night they'd had a long-standing excellent surgeon who does this in Hamilton routinely, and he missed the 200 emails and conversations about this. So that now means there's somebody in Ontario, Quebec, and Alberta. That's reasonably good coverage for epicenters, and Joe even has a care path data collection process and forms for us to complete when we do this. So this all exists under the hood in HiRO if we avail ourselves of it.
Thank you. Paul?
I think all of those presentations were absolutely outstanding and really balanced, so thank you very much. I hate to be difficult here. I'm going to come back to the comment I said earlier, that I think all of the risk calculators were developed in a very special patient population. And these are patients that have been referred to a quaternary care center and are willing to undergo follow-up. Almost all are either close families of probands or people discovered by some reason. What I'm not concerned about, but certainly when we look at the autopsy data, which we have terrific data all over Ontario, where everybody under 45 who dies suddenly gets an autopsy. The data we have collected suggests that the actual death rate in the general population, who never see an electrophysiologist, most of them, is probably tenfold less than what we see in these. I'm sure the risk calculators are correct. I just think that we're only covering a certain proportion of the population. So the question for everybody is, accepting that this is completely reasonable, what we've heard for today, in 5 years, everybody's going to have an MRI at age 18 for some reason or another. Certainly people are having echoes for reasons that I can't fathom, but lots of people are having echoes because it's Tuesday. There's going to be AI reading ECGs with anterior two-wave inversions, which we see in virtually every single, not every athlete, but certainly a high proportion of athletes. People are going to be discovered. There's going to be automatic reading of ECGs with long QT. We're going to, I suspect, in the next 10, 20 years, have a very large influx of patients who will be referred to centers because they actually have the phenotype, or maybe they have the genotype because they went to 23andMe. And those individuals, I don't think, are necessarily represented in the risk calculators that we have. We're going to have some challenge in trying to figure out what the actual risk is in this large, previously unstudied population.
New cohorts to study.
Indeed, so you're totally right, Dr. Dorian. I think we already see this. We right now see, I speak for my colleagues, that the older spectrum, HCM is a very good example because the diagnostic criteria are so poor, so little discriminative, right? So, I mean, our clinics over the last 10 years already are flooded with often elderly patients who typically also have some cardiovascular comorbidities and have just like a septal Barrella, and they just fulfill this very poor criteria of septal to left posterior basal ratio of 1.5, and then you're in. And most of them are gene elusive, and they're 75. And by the way, what we see, you don't need this or this big machinery. So you're right, we will probably see the youngs. I think we need data. We have to study these cohorts and develop completely novel tools, I think.
Just models need to improve with time. So I think we need to periodically recalibrate in different populations and make sure they still work. So I think that's an important part of using these models. And you also talked about this population of patient, of autopsy population. So this is another, we have a higher risk population because we study them, but this higher risk population of patients who are dead before we knew about them and never were studied in risk calculator because they don't have clinical predictors because they happen to be dead before they had clinical predictors, is another interesting population, which, I mean, I often think about, but I don't have any solution to try to predict events before we know in these.
And I think we're uniquely positioned in Canada because I think the question always is, okay, Mike Ackerman's patients with long QT syndrome do extremely well. Does that apply to our Canadian patients with long QT syndrome? And I think where we're aligned and yet heterogeneous, we can really move the needle and try to create more reflective populations and risk calculators that may really be helpful in terms of answering these questions and helping us sort out if our patients really fit into what's been published or what we can actually do here in Canada, which probably helps us more on a day-to-day basis.
Dr. Golub?
I think we all agree that the risk calculators have some limitations. I mean, they're valuable. One of the limitations is that it doesn't take into account mitigation of risk by medical therapy. I know the easy answer would be there's never been a good medical therapy randomized trial to prove decreased mortality for HCM or ARVC with certain drugs. But I think we also know that risk is mitigated for the most part by beta blockers. As it is for other conditions. I think we would probably agree on that, or other antiarrhythmics. And so I think as we look to improve risk calculators, one of the issues to implement is response to medical therapy. I mean, because that could change your PVC burden, could change your vulnerability to non-sustained VT, which changes your risk score. Just wanted to put that out there for your thoughts.
I had an indirect answer. Can you hear me? Hello? Okay, now it works. So for beta blockers, for ARVC, we don't have any data showing that they decrease the rates of events. We like to use them because we all love beta blockers. We know, however, that PVCs tend to decrease with time. PVCs are associated with the risk of event, and we can update the model with repeat Holter and new level of PVC. So that's kind of an indirect way to adjust the model if, for example, beta blockers would decrease the number of PVCs.
I think there's another aspect that is in no risk calculator model is we don't understand the autonomous nervous system, which I think plays in almost all of these diseases, despite the genetic predisposition and other known or unknown modifiers, a crucial role. Some of these diseases have circadian rhythms of arrhythmia and patterns and all that, but we don't understand that. I mean, the same concept as for scar maturation, even for non-genetic disease, right? Patients after their myocardial infarction, they have the scar for 10, 15 years, and then they're doing VT. I think this is another issue because it's hard to understand, and this has to be addressed somehow.
I have a question for you, Christian. The European risk calculator for HCM, I love it because I can put all sorts of things in, and then I can show my telephone to my patient and try to justify the discussion of the shared decision-making about to come on. You mentioned the left atrial size, and the way that we do the echo doesn't really qualify for that anymore. But I wonder if, I mean, why would left atrium be important anyway? And I wonder if it's diastology, and I wonder if we have other ways of fitting that into a new risk calculator for hypertrophic cardiomyopathy.
Yeah, it's a great question. So for the interest of time, so the way how it was put in, this is a classic example, the O'Mahony paper, what happens when you put in a bunch of pre-specified parameters and you do a logistic regression. Something gets a significant score at your univariate analysis, and then you throw it into a multivariate model. And we all know a lot of depends on how much you put in which order, right? So these models are not per se a guarantee of rightness. So probably it does, but I think the way how they put in these parameters is not helpful. So I think with the imaging tools that we have, we should put this information in, like ventricular filling pressures or patterns. These tools are there, but we have to use it, like 3D strain, all this stuff is now much more easier feasible. So I think there might be some value of the size of a chamber or what, but probably not in this very poor way. But to be honest, it's a first step, this model. It's now 10 years old, hasn't really been updated, so I think it's time for something new.
Are we going to draw this to a close in the interest of time? Do we have time for more questions?
We're over time.
Okay.
Probably finish at 5:30, so I think that's great.
Okay, thank you, everyone.